All right, good morning, everybody. Unlike the two prior speakers, I'm losing my hair. I don't have a lot of gray hair yet. I've been doing orthopedics for about 20 years now. My font is a little smaller, so I'll look up there. I live in Destin, Florida, and I'll tell you a little bit more about this around the 10 o'clock session in the surgeon pod. I am sort of similar to Dr. Jacobs here, the funnel where things get bad. Everything south of Atlanta and Birmingham seems to find me on the coast. I was highly academically trained. I worked at shock trauma. I had my own lab. I had a bunch of NIH funding there. Then I had 4 children in inner city Baltimore. And me and my wife, who's a neuroanesthesiologist, decided to raise them elsewhere. And that brought me to Northwest Florida. And some people say, inappropriately, it's the redneck Riviera. There is a lot of questionable healthcare, to be perfectly honest, not throwing anybody on the bus. But I got there with the idea to do trigger fingers and carpal tunnels and maybe an occasional ACDF. And it turned out it's an entirely underserved population where there was a lot of iatrogenic deformity, right? Surgeons that tried to do reasonable things with maybe inadequate skills and training and left patients horribly kyphotic. For people that do orthopedics and not spine, that's when you stand forward, right? So the outcome of spine surgery is directly related to the ability to stand up straight. So I suddenly built a practice with a tremendous number of large osteotomies, giant constructs, and things that nobody had seen in that area. And I do long construct, primarily more minimally invasive procedures, because I realized from being in academia, especially at shock trauma, where people came in 2 pieces and we put them back together. If there was a problem, the resident got called, he got with the medical student and the chief resident. If there was a real problem, the fellow got involved. I never knew about gaping wounds, large infections, and all that kind of stuff, because with all due respect, in academia, you're pretty shielded from that stuff because there's multiple layers of things and people that prevent you from your phone call. If you are by yourself in the middle of nowhere on the beach and there's a problem that somebody needs more Tylenol, you as a surgeon get the phone call. So you can imagine if you start to have patients with infections, open wounds, terrible things after massive reconstructions, I suddenly realized, things need to change. And this is more than a decade ago. So we started to pioneer minimally invasive surgery as a means to possibly help patients with a similar problem, but being able to do it in a more minimally invasive fashion with less wound complications and so on. So this has come to a field way beyond what the industry expected. When I was at shock trauma in 2005, 2006, 2007, we started doing 1 or 2 level minimally invasive constructs, and some of you may have helped design some of this stuff, the early days of Viper and Sextant, for example. But no company had ever envisioned that we would do 10 or 12 levels MIS surgery, right, in the future. This was bottoms-up development from the surgeons, and I know we are maybe more entrepreneurial and tinker along without looking at the evidence. Yeah, that's maybe true, but we tried to solve a really bad clinical problem, right? So we were ahead of the science, and I think now you can see when you go to some of these spine meetings, they have picked up on this MIS type thing, and it's really become like the next wave in spine surgery, right? And if you look at companies, I mean, that's the field that they're growing in the spine world. So that's what I do. I do long constructs, mostly MIS type surgeries, and I try to improve upon bad things that happen, unwanted variation, because that's the thing that drives healthcare cost beyond belief. Variation isn't bad, right? Because variation makes one surgeon maybe a little bit better than somebody else because he's better at doing it that way. Unwanted variation leads to readmissions, infections, prolonged hospital stays, and all that. So whatever we can do to reduce that, that's sort of where my focus is. So I do everything across the adult gamut of spine surgery. We treat a lot of patients with cancer in our little town, and I've done more than 700 robotic spine surgery cases nowadays, and together with Izzy Lieberman and Dennis DeVito in Atlanta, I think we've done more than anybody else in the world with this, because we want to try to automate part of spine surgery so it doesn't go as unfortunate as it has been doing for a very long period of time, simply because of you can't know what you don't know. So if the robot tells you how you should do it, how great would it be to improve the outcome for your patient? I have a history of a PhD in implant-associated infections with Anthony Christina in Northern Virginia after he moved there from Wake Forest. We looked at IgG coatings and coatings on implants, coatings on suture material, and the use of IVIG in a local fashion to be ahead of sort of this complement response that usually takes a couple days, right? And that's where these infections are coming from. So this was in the fear post-antibiotic era that you guys may remember, right? When MRSA and VRE started coming up. So that's an initially where we started looking at implant infection problems, and we developed novel materials, and I did some stem cell work with Giron over at Shock Trauma also to look at nerve recovery and spinal cord recovery. My PhD eventually was defended in Holland at the University of Groningen, and some of you may know that there's a large biomedical engineering department. And when I was a little boy already in my residency, I wrote letters to the FDA and I said, you know what, I don't really understand, and I was very naive, right? We have titanium, cobalt, chrome, and we have some plastics, and we do a little bit of a stainless steel. But the industry around us that flies planes and space shuttles and all kinds of stuff, they have access to stuff that we should really use in people. And I will present to you around 10 o'clock the advance, and we'll talk about it now, of a new material called molybdenum rhenium. Implants were just approved late April, and I think this is going to broaden the scope of what you guys are doing from those really three main metals, some plastics and some bioresorbables, to a new metal with greatly superior biomechanical properties. It has a greater wettability, you can print it, you can do wonderful things with it. So it took about a 10-year quest to get this thing approved by a company in Atlanta. So I am maybe entrepreneurial, that's not my research, I'm sort of explaining this guy to you guys, and we can talk about offline a little bit later what the implications potentially would be. But there are spine implants now approved, foot and ankle implants approved from molybdenum rhenium, and we'll share with you the material properties and the type of implants that can be created from this. So this started when I was a resident, and finally, you know, another 20 years later, here's where we are. I must admit to you, no matter how I love the Emerald Coast, I think automation in spine and computing technology combined can be only advanced at a level that we need in Silicon Valley. So I am transitioning from the Emerald Coast in Florida to Silicon Valley to build a whole new robotic institute surrounding spine surgery. I'll be a busy spine surgeon hopefully there, but it hopefully is a proving ground for new advancing technologies in spine, and hopefully that will flow over to other robotic and automation technologies in other fields of primarily orthopedics. What has worked and what hasn't worked, and maybe we'll touch on this a little bit later when we go through the panel, but I think 3D printing and osteointegration was already discussed, right? I mean, that's been wonderful for us. We always talked about fusion, right? That's the biggest thing now. If you put a titanium 3D printed cage in the interbody space, you fill it with bone graft, on day one on the CT scanner, it looks like it's fused. It's obviously not fused because you just put it in and you can take it right back out. But this sort of cleat-like interface between a 3D printed metal and bone has tremendous advantages. Clinically, you see it because patients feel better than they used to do when you put a PEEK implant in them. They still had a sense of some micromotion despite putting in pedicle screws. If you put a large footprint 3D printed material in there, these people get up and they move and they don't have the same type of back pain. Now the difficulty we have, does it have to fuse? Maybe not really, because as long as there's like 1 or 2 millimeters of some osseointegration to those pores in that 3D printed object that's in there, patients are stable and they're fine, right? So we're having a quest now of trying to figure out how we can visualize this, and maybe we can do this with something we'll come up to a little bit later, to put something smart inside of these cages that can tell us on our iPhone if the stress that you can measure through the cage has gone down, meaning there must not be just loading of the cage, but there is actually solid bone formation going across. MIS spine surgery, we talked about it. The difficulty with us is that we don't really have a definition of MIS spine surgery, right? Everybody's an MIS spine surgeon, whether you operate through a tube that's 14 millimeters or you make just a little bit smaller incision than in the past. Everybody does MIS spine surgery, because if you don't put it on a billboard, right, you have no business anymore. So that's a little bit difficulty, but I think that everybody agrees that less is more in this case, right? The smaller you make your incision, the less soft tissue disruption, the less inflammatory cascade you start on a patient, the fewer phone calls you get about post-op pain, and the faster people obviously heal. And then the molybdenum rhenium, we talked about that. I have some great data to present around 10 o'clock. Greater durability, stronger, it has much less recoil. So as a spine surgeon, bending rods to make a patient's spine straight, the last thing you need is that you bend a titanium rod and you have a 9 to 15% recoil, right? Because then you have to overbend it and it bends back, and then you got to do it 2 more times and the durability is hurt. And not a lot of spine surgeons understand that, right? When you bend a rod one way and the other way and then you go back to the first way, your durability of titanium is like 17% less. I mean, we need to get away from that, and we need to educate people better. And I think with having a new metal we have to start thinking of complete different ways of being able to do surgery, right? So far we've relied on 5.5 millimeter or bigger rods. Suddenly we can achieve the same thing with 4 millimeter rods and smaller maybe. So we can change the way we attach things to the spine, and we can do it in a much more minimally invasive fashion and with less recoil and less ability not to depend on the implant to look the same the way you put it in and that it's going to come out. We can have maybe robots do something much more predictable than a rod that is potentially a lot more flexible at the end of a rod holder, if you think about it. If I move a rod holder with a stiffer rod, then the robot should know where that tip of that rod is. If the rod is relatively forgiving, well, then you might do really bad things if you have automated tools to eventually place your implants. We talked about robotics. I think there's a lot of good things that are coming out of this. We're in its infancy completely, right? And I think the next speaker will completely agree with that. It's first generation, but it's really spectacular, I think, what we've been able to do and how we are now thinking differently about procedures than before. Hip and knee replacement with a robot still has to be done fairly similarly. I think we have to change our thought process that robots don't have to mimic what we do, right? We have to do a good procedure, but a robot might be able to do something completely in a different fashion to get to the same endpoint in a much more efficient way. And we just have not been able to do that because we need to make holes and stick things in there and be able to see most of the time either with X-ray or direct optics. But robots might be able to do things underneath surfaces with image technology that we can't even think about right now. So I think we have to get away from the fact that a robot should mimic what we are good at. Robots can potentially do something entirely differently than what we're currently doing. Things that haven't worked, and I don't mean to hurt anybody, but I think facet replacements, you know, there's some companies come and gone, and there are some new companies now coming up from the past that are trying it again. Hasn't done really well. Well, we talked about tribology before and making things move. I mean, we're in its infancy in spine, right? We want to make things stiff and stable. We do disc arthroplasty in the neck relatively successfully, also with metal bearings, but the lumbar spine has never done very well. Adjacent segment motion is a huge problem, right? If we fix a part of the spine, there's a stress riser at the top, similar to when you do metallic engineering. And unfortunately, people fail as time goes forward. And we can't settle and be excited for maybe a 30-year spine, right? You would be very excited about a 30-year hip. I need to have like a 60 or an 80-year spine, right? So we have to find different ways to help patients with a long fusion to make sure they don't break down at the junction between motion and stiffness. And then, in all honesty, there are some patient-specific implants, right? There is like printed rods that are coming out of a company in France. You send in your scan, and you do your measurements, and then it goes there, and then 2 weeks later it goes back. I think it's neat, but it's not necessarily cost-effective. There's not going to be more payment for a patient-specific implants, at least if we're talking to spine here, than a non-patient-specific rod. So also the patient-specific rods that are bent in the operating room with a tool called Bendini from Nuvasive. It's very neat, but it's not so great maybe. There's a computerized bending system called Arcade from the Mazor Medtronic people. But then the problem is it comes out of the machine, and then it still needs to be sterilized. So that's a window that you're sort of missing in the operating room. So I think we're certainly not there yet. And let's not talk about lasers, because they just put 1,000 people out of work when the Laser Spine Institute went belly up. So that was a very unfortunate thing. Current trends, and I'll run through this a little bit quicker. Automation, right? I think everybody agrees that this unwanted variation needs to be reduced. Robotics and automation are the key to this. Computing power is increasingly more fast. So I think there's a tremendous opportunity there. There are companies called 7D that do things similar to what the Tesla does, right, with optics. The disadvantage is still you need to look at the spine as opposed to keep the skin closed and ultimately get some kind of X-ray or potentially ultrasound to see in real time what's going on underneath the skin. The 2D and 3D ability to figure out where the spine is in the operating room is going to be key, right? We just talked about the better you get your patient upright during surgery, the greater the chances for a good outcome. So if we have real-time tools that are tiny Wi-Fi powered sugar cubes in the operating room attached to a couple spinous processes, and I do my osteotomies and interbody corrections and so on, and the computer can tell me, yes, grandma is now in the right position on the table, then I know I can lock her down, and I know that I've done a good operation. And that information is currently lacking with the navigation systems that are granted from the late 80s, early 90s, right? The refresh rate is not up to par, the accuracy is not up to par, and it's cumbersome to use with all these fiducial balls and things like that that you guys are well aware of. We talked about smart technologies, right? I think this is the key for 3D printed structures, let's say, wherever they're going to go, to see if there is just loading of the structure or if the microstrain sensor that is also Wi-Fi powered inside of an implant can tell us that, you know, the metal is no longer loaded. There's actually bone that is growing and the bone is sharing the load, and it shares that with the patient's own phone along with patient-reported outcomes, devices, smartphones, Fitbits, those kinds of things. It goes directly to the office so we can intervene and we know exactly what's going on with the patient and can tell them, yes, I know you're a workers' comp case and your back still hurts, but it's not just a picture. We can show here that your spine is fused and that it's time to get up and go back to work. Technology hubs, I think, again, not to criticize anything, academic centers are relatively slow to adopt and adapt. And it's hard if you're a well-respected professor and there's very fast new technology coming that you have to go back and learn that. I think I have tremendous respect for when I do these teachings on robotics and advanced MIS techniques and other things we talked about, and I have people that were the gurus that I was taught by in the past, and they have the humility to come down and say, you know what, I want to learn these new things because I think the people I am training should learn that in my center, in my residency. Because what happens nowadays is that a spine surgeon trained in a well-respected fellowship today is probably learning exactly the same thing that I got taught 15 and 16 years ago, and he has to go out and then find new ways to the lateral spine and so on his own to go through courses and all that, because most of the time the older attendings have never caught up to the new approaches to the spine, like the X-lifts, robotics, and so on. Academic centers are very slow to adopt, and it's not to their fault, but this is what we're dealing with. So when surgeons are coming out, they are going two ways. They either need to have very high demands for advanced technology to do their cases if they were in a fellowship program or so where they were advanced. If they weren't advanced, then they have to go out and learn all these new things. Otherwise, they do still big open surgery for cases that really should be done in a much less destructive way for the patient. And I think this is a hurdle that we have to get over as an industry and academia and private practice together to maybe have combined fellowships and so on. And then there's difficulty to get paid, right? We all want new things and better things, but unfortunately it's very costly. And the problem is that reimbursement is always going down, right? From here on forward, you will never get more money for your new pedicle screws and your new widget and so on. So if we talk about molybdenum rhenium and smart implants with devices inside that cost money, it is an uphill battle to get hospitals to accept it because they don't see more money from Medicare or insurance payers coming in to do the surgery with those implants. So they just see us, you, as kind of greedy, and you make so much more money than the hospital margin of 4 to 6%. So this is something we have to be cognizant of, and I think unless the industry binds and ties somehow with hospital systems and insurers together, it is going to be difficult to keep up the pace of innovation and engineering that is possible because there's simply no money for it. I'll stick to that, and we can have some time for discussion later. Thank you very much.